So next one is a case of Crohn's with strictures. So 57-year-old woman, extensive stricturing small bowel disease. She now has recurrent GOOs, thinking about an endoscopic versus a surgical intervention. So this patient diagnosed with Crohn's in the early 2000s. She has extensive stricturing small bowel disease. She's initially on 6-MP, then infliximab. She has her first surgery in 2001, a small bowel resection with removal of 2.5 feet. 2002, she has a re-exploration with no SBR. 2003, surgery number 3, an additional 1.5 feet are removed, and she has stricturoplasties. She then retries infliximab, she gets anaphylaxis, she gets steroids, and then gets osteoporosis. She tries adalimumab, does really well, but gets worse after 1 year. She has a fourth surgery about 9 years later with an additional small bowel resection and stricturoplasty. She tries vedolizumab. She never responded. She tries adalimumab with and without methotrexate. She then has another obstruction in 2017 and another small bowel resection with a stricturoplasty. So 5 surgeries, multiple small bowel resections, not very much small bowel remaining. She then gets a staghorn calculus of the kidney because she has enteropathic hyperoxaluria and needs surgery for this. She then is found to have a duodenal stricture in 2019, unclear if related to Crohn's versus frequent NSAID use for the abdominal pain she has from her Crohn's. She gets ustekinumab once, but then gets a fever and pneumonia, so she never continues injections. So then this is where the story also becomes really complicated. She then starts to get these recurrent lung infections, and she has a lung biopsy with granulomas. She then gets multiple episodes of pneumonia in 2020, 4 times in 1 year. She gets another bronch. There's concern for pulmonary Crohn's. She started on a Zithro prophylactically. Meanwhile, her GI symptoms are pretty controlled. She then basically continues to have these CT scans with all of these strictures in the small intestine with associated hyperemia. In 2021 and 2022, she has pneumonia again, so 7 episodes in 2.5 years. She has a CT scan in 2022 with narrowing at D1 and D2. With associated dilation. 2022, she basically has worsening symptoms thought to be due to COVID infection, and then she comes back after 3-year hiatus in 2025. The notes from the other hospital, they wanted to try adalimumab. She doesn't do it. She then has 3 interim endoscopic dilations of her duodenal stricture. Last was 2024. She was relieved for about a year, but now she keeps having GOO symptoms. And so people are considering endoscopic versus surgical bypass. She can't eat, she's vomiting, she's losing weight, she has abdominal pain. She also has just significant segmental wall thickening and edema and multiple narrowed and strictured areas similar to before. And she gets another endoscopic dilation this past summer, just distal to the duodenal bulb. And she's dilated to 20. So notably, she's had no medical therapy since ustekinumab in 2019. Adalimumab versus risankizumab were considered per outside hospital notes. It's not clear to me why she opted not to start. So really complicated case, right? Diffuse stricturing small bowel Crohn's, multiple resections show probable at least functional shortcut. Now with duodenal strictures causing repeated gastric outlet obstructions, plus these recurrent pneumonias due to likely pulmonary Crohn's disease. So number 1. And this is also where Dr. DeSouza, if you're on, I can't see, sorry, the whole screen. This is where we would love for you and Sergey to sort of discuss, would you think about an endoscopic bypass or a surgical approach? Her endoscopist at this other place is recommending an endoscopic approach. What are your thoughts?
This is exactly patient you don't want to operate anymore.
Yeah.
You want to send this patient to Dr. Cohen after attempted, I'm being serious, attempted dilation to see what the next step options. So the patient maybe, just remind me, is the patient TPN dependent at this point?
No.
Just losing weight, but...
This is my patient. She's actually, almost all of her care has been at Yale.
Okay.
I see her periodically. And she came to me initially because they thought that she either had pulmonary Crohn's or she had Stelara-induced pulmonary disease, and they wanted to stop the Stelara. But really the rate-limiting step has been these duodenal strictures, recurrent gastric outlet obstructions requiring dilations. And they're at the point where the endoscopist says, let's do an endoscopic bypass of the duodenum. And the surgeon's saying, well, we could do it surgically, but it's going to be a really tough surgery, and you're going to have a very prolonged recovery.
I mean, it's
even if you, whichever one you did, surgical or endoscopic,
The question
What do you
is
do
if
about her underlying?
that's right.
small
So
bowel
it's
disease?
I mean, I don't know to say if you give her any medication, her disease course will be changed. That is unknown, but it's a little bit off that she is not on medication. I would say that much about that. Now, to do successful bypass, you need two descent zones, like origin and landing zones. So you have to know that before you try to do that. You cannot make anastomosis into active Crohn's. So I think we need to have some sort, in even thinking about this, we need to have a proof that we have some area of the proximal jejunum which is spared. We don't want to get into OR and have no.
Sergey, what about, I think these patients will benefit from repeated surgery because no medication can work at this stage.
Yeah.
So what about multiple stricturoplasty?
Which she's had.
Question was, what about
Because you can do-
multiple-stricturoplasties,
you
which
can
she
do
has had many
duodenal
before.
stricturoplasty. I mean,
That is a bad idea because if
Why?
that duodenal strictureplasty,
Okay.
typically this procedure is done most in infants for congenital anomalies, in adults with active Crohn's disease. If that, first of all, that's generally speaking, from experience, it's not recommended, and if that leaks, there is no good outcome strategy. That becomes a fiasco with high morbidity, mortality, because basically you have very proximal fistula with bile leak, duodenal content leak. It's just very, very bad complication to have. So that's the reason people generally try not to do that. Usually it's some sort of gastrojejunostomy with variations of that. Yeah, strictureplasty is possible, but you have to see the price of like what we're dealing with.
So gastric outlet obstruction is inflammatory or is that fibrotic?
It's from what I'm told, it's mostly fibrotic.
So I see.
To answer-
It's recurring. I mean, they just have to bypass the duodenal.
So one of the
The
problem
question was,
with
is the stricture fibrotic or inflammatory? And
but
the
one
thought
of the
is that it's
problem with
fibrotic.
Crohn's disease strictures is there is inflammation all around and then it like scars over. So for you to dilate any kind of lesion, you need to have some normal mucosa against which you push the dilator and then it expands and then retracts back. Here in Crohn's, it becomes very hard because it's completely fibrotic through and through. And to your second point about the landing zone, that's even difficult even if you do a endoscopic bypass.
Sure.
Because
Sure.
you don't
No,
know
no,
whether
I
this
don't
stricture will be the one causing the problem or the
Yes.
strictures down below will be the
Lionel,
issue.
are you on?
Lionel, you on?
That's why I mentioned Louis Cohen's as a first,
He's not.
Is she eligible for any clinical trial, for example?
TL1A?
TL1A or any
No,
of the
I mean,
other?
medicine will not work. I mean, no.
She
We
would
have
not be eligible
somebody
for
on
any
the panel who I was
trial.
hoping
Not-
would weigh in, which is Dr. Cohen.
That's what I felt.
This patient.
Yeah. What's the thought about, well,
Yeah.
the second question is sort of, you answered this, how do the downstream strictures weigh in? And we talked about this. Her small bowel disease, do we think that she would, and her pulmonary CD, should we think about a medication in addition to all of this versus stem cell versus maybe a combination? Because she obviously isn't going to immediately get
Yeah,
a transplant anyway.
EMT for the small bowel and for the lung.
About a small bowel.
yeah. I mean,
As opposed to a stem cell.
I would say that, one thing is that this isn't an endoscopic answer. That I agree with completely. And I think to all the
This
points,
is an endoscopic
is
answer.
not.
Is not.
No, just because it's not clear what you're dealing with afterwards without a surgeon actually seeing the bowel and making the right decision at the time. Even the endoscopic approach could be a problem. If you really think if you really characterize the duodenal stricture, and I think to Abik's point, I agree with, it's rare that you're dealing with something that's just purely fibrotic. And so, occasionally we've done some stents in some extreme cases, like one of our patients where we've had to, I think, Nick presented that here once. I do think BMT is not unreasonable. I think that the biggest issue we'd have with BMT are her strictures. These patients do very poorly, depending on the nature of the stricture, but that's a setting sometimes where we'll work with the surgeons in these settings where we think we maybe have some way to get out of it.
Why do they do poorly with the strictures?
So basically, with these inflammatory strictures, what happens, they develop almost like a typhlitis picture, right? Is the way that at least we think about it. I mean, I can't tell you for sure because we're not scoping somebody when they're neutropenic. But basically, anywhere where the bowel's inflamed, it gets worse transiently during transplant. So, patients that have really tight inflammatory strictures, they tend to obstruct. We manage them with TPN. Sometimes we'll even have like NG tubes down. to try to get them through that phase. For a lot of our patients, we've done sort of very modified resections at times where we've like left behind diseased colon or resected one small stricture. We had one patient who had a microperforation during the mobilization because of this. So it's challenging, but we can do it. I think that the other point, something that Sora brought up earlier, this is somebody where I do think genetic testing is absolutely reasonable. And these aren't phenotypes we see all the time, and pulmonary Crohn's is strange. And if it is.
Although it's interesting, it was non-necrotizing granular. Yes, it's
Well, I mean, also just a chronic inflammatory state, and why do they have all these infections? But
had 7 pneumonia.
Yeah.
What would genetic testing tell you?
well, if there's a primary immunodeficiency that hasn't really been picked up, I mean, the NVTA is pretty cheap for that panel. The hyperinflammatory one's also fairly cheap.
But
and easy to
still,
do.
you've got all the
I think
stricturing disease.
the point that I was trying to make is that even if we don't have actionable data right now, I think identifying some genetic pathways will help in the future.
Okay.
We're sort of flying blind. I think in all likelihood, both these
Yeah.
patients, they probably have some underlying genetic reason why they're, somebody with UC who's refractory to all these drugs. Of course, there are social factors, but he's obese.
Mhm.
Right.
So,
Yeah.
so it doesn't compute somehow.
So
I think-
should he sure see her? I mean, should
Yes,
Yeah,
yes. Because
absolutely.
The question is, should
patient
she be
yes.
considered for a small bowel transplant?
They will probably
was the
decline
question.
her because she's not
Exactly.
TPN independent,
Right.
so it's just not.
It's
They
a
will-
matter of time.
Right. The question I have, any reason not, I understand that impression is, yes, medications may not work, but what if they do? What's the downside?
We would try for sure.
Well, she hasn't really
Not
tried
much
very
left.
many things
If
at
she
all,
didn't try any medical management for years,
Yeah.
so what about just trying?
other
it?
than TNFs and immunomodulators
Right.
and Vedalaz. So, I mean, she has 23s and JAKs.
Duodenal stricture and multiple, but she hadn't had multiple surgeries before. But she clinically improved and actually she had a surgery too
Right.
on
You just
with
don't know.
IL-23 and Rinvoq. Now she got pregnant and we're off of Rinvoq, but and she was actually deemed by another hospital as TPN dependent before we put her on enteral nutrition and Rinvoq and Skyrizi and has done very well.
So
with
this
just
is a
one surgery.
patient, Dr. Lavanos mentioned, who had a duodenal stricture, but not all of these prior resections,
Yeah, no, exactly.
who responded very well to a combination of IL-23 and JAK. Even though she had been TPN dependent, she got enteral nutrition, these two meds, and did really well, but it's a little bit of a different phenotype. The question I also would ask is, what about the pulmonary Crohn's? If you're concerned that this is pulmonary Crohn's, would being on a biologic or small molecule be important for that, even if you don't think you're going to make a lot of headway with the
Yeah.
intestinal
I would
disease?
sure try.
Yeah.
Definitely not out of the,
I think
well,
one of the.
you said systemic, I mean, like, clearly,
Right.
they're missing.
I think
And
it's
she
a-
didn't do well with Veto anyway. So what would you choose a 23? Would you choose a JAK?
I'd use combination therapy, but I think this is
Of those
something I
two.
really think about, like, one of the new agents under clinical trial that's gonna both be an anti-inflammatory and an anti-fibrosis.
She won't be eligible for any clinical trial.
The comment had been considering a clinical trial, but then the response that she may not be eligible.
She's not gonna,
And I mean, we don't know exactly what happened with the Humira, so we can theoretically do infliximab. on
Right.
her,
Well, infliximab, she had anaphylaxis.
Oh, she had anaphylaxis, sorry about
The
that.
Humira, she's tried, adalimumab, she's tried twice without an adequate response, one time sort of off and on with methotrexate. So there had been a question of trying again to reinduce her with adalimumab versus why not try at this point? She doesn't have any other risk factors associated with a JAK, so she could certainly try other than her infections, but theoretically the infections may be because she has underlying untreated pulmonary Crohn's. So maybe upadacitinib plus a 23 would be your best bet if
I
you're
mean,
trying medical therapy.
And this would be the person that you would try nutritional therapy on, maybe TPN, EN, whatever you need to do at this point of time while we get some headway.
So we're at the point where the endoscopist is chomping at the bit to do an endoscopic bypass. We all agree that's not.
Because
not a
he
good
doesn't
idea.
know where he's going to. I
He's
just.
not that eager, but he feels like there's nothing else he can offer.
Right.
And that's the next step. The surgeon's not too eager, so I guess we'll bring her down here and work her up more.
Even if he
Perhaps.
bypasses, there might be strictures downstream
Oh,
from
that's
that
the
area.
problem.
That's the
Mhm.
problem.
And
There are strictures down.
Right.
And an
Yeah.
endoscopic bypass is really just a lambs, isn't it? It's just,
Yeah.
you know,
Right.
that's gonna clog.
And
that's
it's like a
gonna-
floppy small bowel.
Yeah,
It's
yeah,
hard to do
so,
it.
Okay.
It's no
Um,
great
we'll have
permanent
So
solution.
someone suggests that they don't do something with the stem.
Yeah.
What's that? Yeah.
I don't know, internal
that's-
nutrition.
Okay, well,
Absolutely,
thank you,
100%.
The fact
Guys,
that she had
thank you so much
three
for all of your
explorations
participation,
in
for
3
being
years
here.
for stricture.
Glad to
This
see
is
that.
completely off.